So I'm very grateful to Dr. Brinkert that helped me to convince you that imaging is not the actual answer to our disease, because we still have a lot of open questions, and I am also grateful to the organizers to give me such a remarkable task to look into the future, what we'll have. And even though they gave me a title which doesn't include deep endometriosis, I will nevertheless try to focus more or less on that disease in order to be able to debate. So you have heard what deep infiltrating endometriosis is, but what I'd like to point out to you is, in addition to the definition, is that we are dealing with a disease which is not entirely by itself. I mean, this entity, but there is a rather high percentage of co-localization with other entities. So it's very difficult to look just at deep endometriosis. In the most studies, it has not been really excluded that you are dealing with something else than deep endometriosis. So what are the problems with that entity? Let's call it an entity. I pointed out in my first lecture that we have a huge delay of diagnosis. So there must be something really wrong about diagnosing this disease. And since endoscopy is an invasive procedure, one would wish that you have a good imaging to decide whether somebody has endometriosis or not. But since we don't have it, there is a delay. So I think this actually tells you that imaging can't be that good yet, or not good at all. And then we have a very high recurrence rate. So if you could diagnose it by imaging, you could treat it properly and you would not have this high recurrence rate, as has been already pointed out by Dr. Brinkert. And then, as you know, this disease appears to be chronic. So if it's chronic, then you would have to do some kind of diagnosis all the time to see when the disease recurs. So in my opinion, if you ask me, does imaging help diagnosis, I could tell you it may help to locate the disease, but that's it. And I think if you want to have a diagnostic technique, you would have to fulfill these essential requirements of diagnosis. And that is a problem with imaging. You would have to predict the active disease, because then you would say, then we treat it. You would have to determine whether this disease will influence infertility in order to help women who are wishing to become pregnant. That obviously is not possible with imaging. And assessment of prognosis by imaging would not be possible and has not been shown yet. And also prediction of response to surgical treatment or medical treatment has not been shown. So we are dealing with a big problem if you would like to use imaging, because the diagnosis of the disease initially is actually based on clinical examination in most hands. And the problem with deep endometriosis is that you have co-localization of other disease, so you could have actually something else apart from deep infiltrating endometriosis. Further on, this deep endometriosis may not correlate with the extent of pain. So you may discover it on functional MRI, for example, but it may not correlate with actual disease. And it may not be necessarily the cause of infertility. So the problems with imaging are that it's, if at all, it is a reliable technique mainly in the hands of experts. In a country like Germany, most people don't do it. So experts with extensive training may actually discover whether there is some adenomyosis or not, but not in a general routine. And if you look at the studies with imaging, you have actually reasonable results at most only in very specialized centers. So you can't actually say that imaging will be applicable, and just in a few cases you would be able to use that in a general routine. And even if you look at the publications, let's take rectal ultrasound. You can see that sensitivity and specificity is actually, in many cases, quite poor. So I told you that I wish imaging could actually predict response to medical therapy, but there is no prediction. There is no assessment of prognosis, whether there has to be a certain medical treatment or not. You cannot predict length of treatment, and as you can see, there is a high recurrence rate. So somehow we are not doing it well. And even with surgery, even though you may locate the disease, but you cannot really predict the response. So it's not sufficient to diagnose the disease whether you're actually treating the patient well. The same applies again with prognosis. You cannot actually really assess prognosis. So we are actually doing bad with that. And even with surgery, I'm afraid to say, the recurrence rate is rather high. But nevertheless, we have to decide if we're talking about pain and infertility, or actually both. So in all cases, we'll have to keep in mind that we are heading at two different entities. Now let's take pain, dyspareunia, which obviously is quite difficult to image. But what I'd like to show to you here, that in a study which has been published by Vercellini, surgery did quite well in the beginning, but in the end it was not that different from patients if you use just progesterone or progestin. So what does this tell you? If you operate on a deep endometriosis and you actually are not really able to tell if one or the other would be better, then it's bad. So you would actually need something to predict whether you actually have to remove it or better treat it medically. Now, what about pregnancy rate and what about infertility? If you look at these data, these are similar to the ones been shown by Professor Dyer, that basically in some publications, pregnancy rate is not really different if you operate for deep endometriosis or not. So, if you accept these essential requirements for a good diagnostic methodology, you would have to fulfill this list I've been just telling you about. Now the answer would be to tell what these things using biomarkers. Now luckily I was given a lecture saying a future of the use of biomarkers, because obviously, as you know, there's no biomarker part, maybe apart from CA125, is presently in use. So we need something really tough. We need something to scare the disease, and we have to diagnose it. So since it's quite late in the day, I thought I'd give you something of a championship league picture. Now, let me bring you to another disease where I think this solution is a little closer than in endometriosis, and another endocrine-dependent disease is breast cancer. Now, as you can see here, estrogen receptor is used as a biomarker to tell you if the disease can be reduced. And as shown here, tamoxifen and anti-estrogen can actually do that. It's obviously not imaging which helps you, it's about the biomarker if there is a receptor. Imaging shows you there is something, but it doesn't tell you whether it will react or not. So you need a biomarker. And that's what's here. And then you can use a drug. And that's what you need for endometriosis to say. And that has been shown in many, many studies for breast cancer, that if you have a good marker, estrogen receptor, if it's positive, this will work. If the biomarker is not there, it will not work. right? So if you try to accept that similarity, then you can look at this slide where biomarkers are used in breast cancer to tell you which type of disease you are dealing with, because it is heterogeneous. And I think this is similar in endometriosis. So you would have to subdivide the disease, just like as in breast cancer, using biomarkers in order to tell whether the disease has high differentiation, will be responsive to either hormone therapy, chemotherapy, or tell about the prognosis. And that's what's shown here. So biomarkers are able to do that. Now, if you go even beyond that, you can have numerous biomarkers. So if you have the 4 groups of breast cancer types, you can use more than just estrogen receptor. Additional gene expression profiling will actually help you to tell even more clearly what type of disease we are dealing with. So I think this could be the answer, using biomarkers for diseases which are so complex as endometriosis. Now, what do we know now? Do we have something in hands now to predict future? I think we do, because if you look at the disease, endometriosis cells, and if you compare it to the so-called mother cell type, you already see that there is a difference just by looking at the receptors. Normal cells, endometrial cells, are very poor in estrogen receptor beta, whereas very high in endometrial cells. So looking at that, you can already say there may be something which tells you that this is a different type of cells. Because if we accept transplantation theory, then you would assume that endometrial tissue will come into the abdomen cavity, and you may not have such a difference in estrogen receptor beta. But cells which may make problems in the pelvis change. So you have a biomarker already. Another biomarker is progesterone receptor, and if you analyze normal endometrium, you have a different ratio of A to B than if you look at ectopic endometrium. So you do see something, and interestingly, even in these women, their normal endometrium, utopic endometrium, shows already some change. So you already have a biomarker which may actually help in future. Now, I don't want to go through all the different types, but I'd just like to point out we are doing different areas, research in different areas, and I'd like to tell you about some of it. Important things are how the disease, which will make problem, gets to additional angiogenetic factors, how they will grow, what's the immune surroundings, etc. And there are other interesting areas such as stem cells, regulatory mechanisms. So one I'd like to point out to you is how can we actually tell which disease will have what prognosis, how it will react. Now, one possibility is microRNAs, because microRNAs have been shown that during the development of tissues, just as it's happening in endometriosis, you can have different molecular mechanisms. And you don't have to read that, but it just tells you that you can have biomarkers to understand the different pathogenetic pathways. And if you put all that together, and that's in a review article on endometriosis, right? So you can have all these different type of regulatory mechanisms which could be applicable in future as biomarkers. Now, I just give you another option, because we are totally surprised that in some patients, even if you do good surgery, do medical treatment, they will not really do well. They will recur, etc. And we suspect that stem cells may be the answer to some of it. And there are a lot of data in other diseases, but in endometriosis we have shown, like just as others, that there are stem cells which are different from the differentiated endometriosis cells. So we may be treating endometriosis cells, which are differentiated quite well, but the stem cells have different responses. If you look at these stem cells, they don't have receptors for steroids, what the differentiated endometriosis have. So if you are able to demonstrate that in some women these cells are present, you will have some biomarker to tell or even predict that some treatments will not be efficacious, and actually it may help to develop other treatment modalities. So we looked more closely at different stem cells, and we looked in the stroma, just as we looked in the glands. We found these by markers. We discovered these just as others, and were able to locate these cells. Now, an important issue is pain. If patients have pain, you would like to understand, is that related to endometriosis or not? So quite a number of studies have shown that there are nerve fibers which are present in endometrium or endometriosis in women with endometriosis, which are not present in women without endometriosis. So I just highlighted you some of these markers which one could use to determine this. And one of these markers is called PGP, and this has been looked at and is looked upon as one potential marker to understand if women who have pain, whether this is related to this marker, and eventually we may be able to treat it. And also the extremely difficult cases of endometriosis, where you actually can't really always tell whether this is actually a cause, if you can't actually tell whether it is present. But I think, as it has been shown in publications, if you could demonstrate that in these women there are abnormal nerve fibers there, that will be helpful, and you could use it as a biomarker. So I'd like to finish and tell you that I believe that we are dealing with quite a different range of disease, and you could have deep infiltrating disease, you can have more peritoneal disease, different activities, it can have invasion in different tissues, but you have to understand that just like in other diseases, and I showed you it in breast cancer, you have to have a biomarker to understand if this implant has anything to do with a disease, or whether this has anything with a prognosis with pain in future. So you need to have biomarkers to predict treatment or response to treatment and predict prognosis. Now, if we take all the biomarkers which have been investigated for endometriosis, I think we'll may be able to pick up certain types of biomarkers in future if we are applying them in studies, because you have to understand that you can only tell if a biomarker works if you do proper studies. And I think this is not easy in endometriosis, but in future we need to do that. So I think that some of the markers which are potentially useful I've pointed out. I think microRNAs are very good markers because you can easily measure it in blood, and even stem cells you could actually discover in small biopsies. So I think there's a potential for the use of these biomarkers. And eventually you would have to distinguish by using biomarkers whether disease is really severe and this is the cause of the problem, or are you actually just dealing with normal cells and the problem comes from somewhere else. And I think we need to have to do something about the field of endometriosis. Coming back to football game, I mean, this is a rough game. If you don't have a good way of predicting how you're going to end in this difficult field, you will never able to make a good treatment if you don't make good diagnosis. Thanks so much.